Ladies and gentlemen, please welcome Dr. Abubakr Bajwa of Ascension St. Vincent's.
Thank you, everybody. It's good to kick off this day. I'll be talking briefly about some of the advances that have happened over the past probably 5 to 10 years in the field of pulmonary medicine. There had been a significant gap between technology coming out of the west of the country and other places and actual medicine, and that gap has been narrowing slowly over the past few years. So the topic is going to be state-of-the-art in pulmonary medicine, role of robotics, interventions in COPD beyond medications, and also options in sleep apnea. Lung cancer screening programs are widely developed and available based on the lung cancer screening trials. To have a comprehensive program, you have to integrate diagnosis, tracking, evaluation, biopsies, and surgical resections and treatments. We'll talk a little bit about that. There are some minimally invasive techniques coming out in terms of improving quality of life in patients who have COPD. We know there's options of lung transplantation and surgical lung volume reduction available, but those are invasive, limited, not everybody qualifies for it. Sleep apnea is also very prevalent across the United States, has significant impact on a number of comorbid conditions. Controlling sleep apnea traditionally has been an issue because of the availability of options beyond what we traditionally know as CPAP or BiPAP devices. And then we'll talk about a little bit about research and advances in technology and where to look forward to and where do we look in the future. So lung cancer. We know that in 2014, there was the National Lung Cancer Screening Study that showed that if you did annual low-dose CT scan for lung cancer screening, you were able to save 20% of the mortality related to lung cancer, 20% of those lives, if you detected lung cancer early. The recommendation has been widely available since 2014. It's taken a while for institutions and groups to implement that and to develop a program where you can diagnose lung cancer or spots that are suspicious for lung cancer, track them, biopsy them, and take them to definitive therapy. The best outcome in lung cancer is early stage. We know that. Most of the stages that we see on screening are small nodules, tiny nodules, typically less than 2 centimeters. They're usually on the edges of the lung, but if you take care of those nodules early, you can see survival, 5-year survival of 92% or 83%, depending on the size of the spot. The size of that nodule also poses challenges traditionally, because our traditional bronchoscopy techniques, although safe, less invasive, but their accuracy was dismal. Somewhere 50 to 60% accuracy in terms of diagnosis of lung cancer. Along came what we call electromagnetic navigation, which overlaid CAT scans that are available to develop a virtual image of the patient's lungs and airways to guide us through those areas to get to the spot that we need to biopsy. It added very little, generally speaking, now that we look back. Although still safe. CT scan guided biopsy, that's usually done by interventional radiologists, increases the accuracy, but at the same time, it's more invasive. There's a significant higher risk of collapsing the lung compared to the traditional bronchoscopy technique. So we really needed some sort of a technique and advance where we are picking up nodules because of lung cancer screening trials earlier, but we had limited ability to biopsy them and confirm whether these are cancers or not. Now, why does that matter? Well, you can say, okay, if there's a nodule, you're suspicious about it, you can take it out with surgery. But we look at the data, 10% of the no biopsy nodules that are taken out with surgical resection in high-risk patients were benign. So when you take a part of the lung out for a benign spot, that person loses the ability to have another definitive surgery for a true cancer that may develop later on in their life. So it's essential and important for us to diagnose it, properly diagnose it, stage it, and get it to treatment. So Intuitive, which makes the Da Vinci robots, came up with this robotic platform called Ion. There are a couple of platforms available, but we use Ion. We were one of the earliest adopters of the technology. We had a thriving lung cancer screening program. We had plenty of nodules that we were able to pick up but not do something about it because of the location, the size of it. And since April 2020, we have done about 400 cases. And across the board, regardless of who's performing the cases, our diagnostic yield is 90%. Now you can compare that to traditional bronchoscopy where the diagnostic yield was 50 to 60%, and CT-guided biopsy diagnostic yield has been about 80%. So that has given us tremendous amount of stability, reach in the lung, and diagnostic accuracy, so we can pick up these nodules that are seen on screening, diagnose them appropriately, get them to proper treatment, definitive treatment. Now, there are certain patients who will not qualify for surgical resection or other treatments. They choose not to do chemotherapy, they don't want to do a surgical resection because their lung function is not enough. What are the options for those? So there's traditional radiation therapy. But now we're looking forward into the future, and hopefully soon we'll have a clinical trial where we're looking at lung nodule ablation, meaning you've done all of your workup, you have a nodule, you go in and you diagnose it, the pathologist reads the biopsy right then and there and tells you, okay, yes, this is cancer. And to the best of your knowledge, you say, okay, well, I can treat this because it's early stage. You can take a catheter out to the nodule, ablate it, and be done. So diagnosis, staging, treatment in one go in one day. That's the goal. Well, let's switch gears a little bit. Let's go about COPD. Again, another very prevalent condition in the United States. The role of traditional medicine in COPD has always been to improve quality of life and reduce exacerbation. Traditional medicine is inhalers, medications, sometimes pills, and as patients worsen or they advance, despite them stopping smoking, despite best of your efforts, their main complaint traditionally is the shortness of breath experience. We refer patients for lung transplantation. Obviously, there's limit to how many organs are available. Transplantation is a great option. It does improve their quality of life and longevity in some cases, but not everybody qualifies for it. So were there any options beyond medicine that we can utilize and use to improve these patients' quality of life? We had been looking at non-surgical option for lung volume reduction for a long, long time. Some of those trials didn't pan out. Eventually, with the advances in technology and our ability to analyze these patients' lungs, trials were modified, and now we have ability to deploy endobronchial valves in patients whose lungs are full of emphysema, are overinflated, to shrink their lungs down and give them better quality of life and less symptoms. We have two different valves available. One is made by Pulmonx called Zephyr valve. The other one is made by Olympus called aspiration valve. Both of them do the same thing. We've done about 100 cases, 80% success rate. 80% of the patients feel better after you deploy the valves in the appropriate part of the lung to shrink that part of the lung down. Sometimes the improvement is immediate. It takes up to 2-3 months for it to get better. But there's more advances coming in. How can we recognize even better population that will work, that the valves will work for those patients with more accuracy in determining that this is the right procedure for you? These are minimally invasive. If it doesn't work, you take them out. There's no cutting, no incision, no surgical process. Finally, let's talk about sleep apnea, another prevalent condition that has been around for a while. Traditional treatment for sleep apnea is primarily what we call CPAP and BiPAP. It's great, it works wonderful, it's gold standard. Problem is tolerability. If you look across the board, certain literature will say 50% of the folks that you give CPAP or BiPAP machines, or what we call positive airway pressure machines, they do not tolerate it. Well, why does it matter for us to control sleep apnea? Because of its relationship to a lot of other comorbidities. Cardiovascular risk of heart attack, risk of strokes goes up, risk of recurrent AFib or development of AFib in certain patient population. To control those comorbidities, it essentially we treat sleep apnea. What are the options beyond CPAP, BiPAP? There is something called an oral appliance where you can use it to help with them, and now we have availability of what we call a hypoglossal nerve stimulator. It's an implantable device to stimulate the nerve to keep the muscle tone in the throat and get rid of sleep apnea. Ascension St. Vincent's, we have done about 75 cases successfully, and it's a great option. I think I skipped over one thing here. Another significant issue in COPD has been exacerbations that requires hospitalization, that increases morbidity, mortality. How do we reduce it beyond medication? Well, there is a lot of interest in denervation of the lung. So we have an ongoing clinical trial where we are using this new technology to denervate the lungs in folks who have frequent exacerbation to reduce future exacerbations, reduce hospitalization, and also subsequently improve quality of life. And that's called the bronchial denervation study. The study is called AIR-4 clinical trial, just an example of what's new out there in terms of devices. So what does the future hold? Obviously, over the past few years, we've been able to narrow the gap between technology and medicine. And the future is probably going down that path. Incorporating artificial intelligence to accurately predict our outcomes, choose patients, use of nanobots and smarter robots to give you reach and stability and accuracy down the road. So the time is very exciting. There's technology coming in the next few years, and we'd like to stay ahead of it and be the leaders in it. With that, I'll stop.